So when these clinical studies start failing and showing that while in the mouse actually it might be promising, but in the patients it was quite toxic, that's when the lab became interested in understanding the mechanisms of action of these antibodies. And in summary, what we discovered was that the back end of these antibodies, the Fc domain and its interaction with the inhibitory receptor FcγRIIB, it's critical for the in vivo activity of these therapies. So in summary, most of the first generation antibodies do not engage FcγRIIB, and when they do not engage this receptor on the back end, it doesn't allow the antibody to the efficient cross-linking of the CD40 receptor that is needed for signaling. But when we actually take these antibodies and we modify the Fc domain to increase binding for FcγRIIB, we find that the cross-linking of the CD40 receptor is more efficient. We promote effective trimerization of the receptor, and that results in increased dendritic cell activation, cross-presentation, and ultimately leads to enhanced T-cell anti-tumor responses. And when we use some of our humanized mouse models that express CD40 and the human Fc receptors, we are not only able to recapitulate the anti-tumor effect, but also we're able to show that, recapitulate some of the toxicities that we see in the humans. And that's when we start looking for alternative delivery systems for these drugs. And that's when we discovered that the intratumoral or intralesional administration of the drug can not only promote local anti-tumor response, but also it can lead to systemic anti-tumor immunity. So, it took a lot of years in the lab to figure this out, to develop the adequate mouse models to have these findings. And that ultimately resulted in bringing a molecule called 2141B11, which is the Fc engineered antibody with increased binding to FcγRIIB to patients. And what we presented at SITC was actually the first phase 1 study investigating the safety and some of the preliminary clinical activity of the drug.